Welcome to SpineUniversity. Over the course of the last 2 years, we've done a comprehensive evaluation of the feasibility of adding a spine service line here at Newton Medical Center with the goal of providing comprehensive, evidence-based orthopedic care to those patients requiring both in- and outpatient spine treatment in their home community. Ultimately, we strive to become a center of spine excellence just as we are for both maternal child and joint care. Knowledgeable employees are the foundation of any successful program. This will be a new endeavor for most of us, and we have a lot of new things to learn. We have some groundwork to lay and some pretty lofty goals to meet. We're an extraordinary facility with extraordinary staff who undoubtedly will meet this challenge head on. Our goal is to be ready by September 6th. This is a huge project with many elements, the most important of which is you. Many of us have not taken care of spinal patients, and we don't take that lightly. Over the next few months, you'll have many different educational offerings that are meant to prepare us for this new undertaking. Please keep up with the education. If you put it off until September, it will be an overwhelming undertaking. Our goal today is to refresh what we once knew about the spine. Our objectives with this training are to review the different structures of the spine: cervical, thoracic, lumbar, sacrum and coccyx, intervertebral discs, nerves, and a brief look at the arterial supply. In future trainings, we'll look at specific conditions and procedures required to correct them. The spine is typically made of 7 cervical vertebrae, including the atlas, which is C1, and the axis, which is C2, 12 thoracic vertebrae, 5 lumbar vertebrae, 5 fused vertebrae that form the sacrum, and the coccyx, which is typically composed of 4 incomplete vertebral processes that are fused in a curved profile resembling that of the sacrum. Alternating between the bony vertebrae are cartilaginous discs. There may be fewer or more vertebrae with certain clinical conditions. The vertebrae each offer multiple surfaces for the attachments of supporting ligaments and muscle. The spine is capable of extension and rotation. The movement between adjacent vertebrae is limited, but as a whole, there's typically a considerable range of mobility due to the different joint structures within the spinal column. Vertebrae typically conform to a specific structure, but there are some differences or variations at the different levels. The first variation occurs at the cervical spine with C1 and C2. The top 2 cervical vertebrae act as the seat of the craniocervical junction. Half of the rotational mobility of the entire cervical region takes place between the atlas and the axis, and the range of spinal flexion is greatest in the cervical region. The atlas is the only vertebral body to lack a spinous process and makes no contact with an intervertebral disc. The atlas also lacks a vertebral body, just like the axis. The axis has a process that protrudes through the atlas called the dens. This is what articulates with the atlas to provide axial rotation of the head as well as nodding, and is referred to as the atlanio-axial complex. The cervical vertebrae offer a flexible column for the support of the head. Because they bear the least weight, they're relatively small and thinner than their thoracic and lumbar counterparts. The most defining characteristic of the cervical vertebrae are the transverse foramen that cage the vertebral artery. The ligament complex in the cervical area is a sophisticated network playing a crucial role in stability and the protection of the body's most critical neurological structures. The 7th cervical vertebrae is considered a transitional vertebrae with characteristics of both the thoracic and cervical vertebrae. The inferior surface is proportionately larger than the superior surface, its angle is more abrupt than the plateau surfaces of its other cervical counterparts, and its spinous process is easily palpable. The thoracic vertebrae are larger than the cervical vertebrae and have a slight wedge shape. The thoracic vertebrae have characteristic costal facets on either side supporting their corresponding ribs. The vertebral foramen is more rounded to support the shape of the spinal cord in the thoracic region, but it's very narrow. Each of the thoracic vertebrae overlap the next from above, with the spinous process projecting downward. The transverse processes are also longer and extend laterally. The lumbar vertebrae are larger than the other vertebrae. There is no transverse foramen and have no costal facet since there are no ribs. The fifth lumbar vertebrae is the largest. Lumbar lordosis begins at L1 and gradually increases at each distal level. The spinal cord usually terminates at the L1-L2 level in adults, where the cauda equina begins. The primary function of the sacrum is to transfer weight from the spine to the pelvic structures, then the limbs. The sacrum is a triangular structure composed of 5 fused vertebrae. There are anterior and posterior forama where the nerve roots exit. The coccyx is also a fused triangular structure that articulates with the inferior aspect of the sacrum. The entirety of the vertebral column has a complex system of ligament and muscular attachments that maintain its stability and alignment. The intervertebral disc forms the intervertebral joint, and in a normal spine, it accounts for about 25% of the height. They are the thinnest in the upper thoracic region and the thickest in the lumbar region. They are comprised of alternating concentric rings of thick fibrous tissue called the annulus fibrosus. The center of the disc is made of a spongy, pulpy, semi-liquefied material called the nucleus pulposus. The primary function of the annulus fibrosus is to withstand tension. The primary function of the nucleus pulposus is to redistribute compression forces with both its liquid and elastic properties. There are 31 pairs of symmetrically arranged spinal nerves attached to the spinal cord by anterior and posterior nerve filaments, which come together to form the nerve root. The vasculature of the spinal nerves is extensive, but there are a couple of important things to know. The vertebral artery enters the spine through the transverse foramen of C6 in approximately 90% of people, which has implications for the anterior approach in surgery. So it's important that the patient is evaluated for vascular anomalies preoperatively. The vertebral artery on the right branches from the subclavian artery. The vertebral artery on the left branches from the aorta. There are 2 posterior spinal arteries and 1 anterior spinal artery that supply the spinal cord. Some of the branching arteries supply both the nerve roots and the spinal cord, called radiculomedullary arteries. Those that only supply the nerve roots are called radicular arteries. When our anatomy fails due to age or injury, surgical intervention may be warranted. Key elements to spinal disorders are pain, numbness, weakness, gait difficulties, and deformities. Spondylosis is a condition related to shrinking or herniated disc and the body's attempt to compensate. Osteophytes or bone spurs form to increase the surface area of the vertebral body as a protective mechanism. These extra bony processes may encroach on nerve tissue. Myelopathy is a cluster of symptoms that result from spinal cord compression, causing problems with gait, balance, and fine motor coordination. Cervical myelopathy is the most common cause of spinal cord dysfunction in patients over 55 years of age. Radiculopathies occur most commonly with herniated discs or spondylosis as a result of nerve root compression or irritation. It will cause symptoms that include radiating pain, weakness, numbness, and tingling along specific nerve pathways. Degenerative disc disease occurs as we age. Loss of hydration causes the disc to dry out and it becomes less compliant. With the inability of the disc to dissipate the compression forces, those forces are transferred to the musculature and ligaments, and back pain may occur. Disc herniation occurs when the nucleus pulposus herniates either posteriorly or laterally and compresses a nerve root. The herniation may protrude with the annulus intact, extrude through the annulus but remain contained by the posterior longitudinal ligament, or it may be complete with herniation into the spinal canal. Pain results from nerve compression or the inflammatory response to the cytokines released by the nucleus pulposus. Stenosis causes narrowing of the spinal canal with subsequent compression of the nerve roots at 1 or more levels. There are several other indications for treatment, some congenital and others from injury or trauma, which we will continue to expand on through additional education. If you are feeling in the least overwhelmed with this information, you're not alone. No one will be alone through this process. If you want more information, we have references available. There's an entire team working in the background to make this process seamless for you, but you will have to engage with the education as it's presented. What you can expect is the continued reinforcement of today's education, reviewing the anatomy and familiarizing yourself with the terminology. We have resources purchased specifically for this project that are in the library. As the education comes out, so will quick references that will break down each procedure, and we'll try to keep you updated as to where we are in the timeline. We're extremely excited to have the opportunity to offer this service as another way to protect and defend our community.